I'll have to get your contact information from Robin at some point so I can hear more about your freezing research. I can't even imagine how you study that. So I'm
Yeah,
curious.
yeah, of course, definitely get it. And you could just email me too. You have my email, so.
For those of you just joining us, we're waiting until 3 o'clock to get started. Our topics today are going to be the near-term pipeline for PD treatments and the far horizon for PD treatments. So stay tuned. We're waiting for about another 90 people to log in before 3 o'clock. Ah, perfect. Thank you.
Yeah, sorry about that.
For those of you who just joined us, we're waiting until 3 o'clock to get started. We're expecting about another 80 people. Okay, we've got about 2 more minutes before we're going to get started. We're talking today about what's in the near-term pipeline for PD treatments and what's on the horizon for PD treatments. So hang tight for a couple minutes and we'll let everybody get logged in. My computer screen says it's 3 o'clock, but it looks like we're just having a flurry of people logging in right now. So let's give it just one more minute. We're expecting about 100 people today, 150 actually. And so far we've got about 30. So people are coming a little bit late. Okay. All right, well, we don't have everybody logged in, but we have some preambles to do before Dr. Blewett is talking today, so let's get started. Good afternoon, everyone, welcome. We're so happy you could join us today. I'm Denise DeGon, and pleased to be here and to host and moderate this webinar for Stanford. We do have over 150 people registered for this webinar, mostly from just in the US. Some health professionals, but mostly lay people will be attending. Today's webinar focuses on the status of research in PD. Is there hope? Topics covered will include what's in the near-term pipeline for PD treatments, what's on the far horizon for PD treatments, and how can you learn more about the research and how to get involved. First, some housekeeping. To ask a question during the webinar, click on the Q&A icon at the bottom of the Zoom screen. That will open a window in which to type your question. A satisfaction survey will pop up at the end of the webinar today. If you can't stay to complete the survey, all registrants will receive an email with a link to the survey later this week. Please complete the survey. We look forward to receiving your feedback. It helps us improve our webinars going forward. A little bit about my background. My father had Lewy body dementia, which was confirmed through brain donation, and my father-in-law had Parkinson's disease with dementia. Currently, I lead a Parkinson's caregiver-only support group in Los Altos, and I'm a case manager with Brain Support Network. Our guest speaker today is Dr. Brent Blewett. Dr. Blewett is a movement disorders specialist at Stanford University. His research focuses on fall prevention in movement disorders, and he recently received National Institutes of Health grant funding to explore freezing of gait in Parkinson's disease. After Dr. Blewett's presentation, we'll hold a Q&A. At this time, I'll turn things over to Dr. Blewett.
Thank you very much, Denise. Thank you very much, Robin. Thank you, everybody, for coming this afternoon. So today's topic is the status of research in Parkinson's disease. Is there hope? I am a fast talker. I have a lot of slides, and I like to go through things to keep everybody interested. So I will go through rapidly. We're going to cover, I've read the questions that have come through already, and I addressed many of those in the presentation, so please pay attention. I will try to highlight those as they come up. And I'm going to skip through some information on the slides too, as it's a bit technical. So we'll mainly try to listen. Don't get frustrated if you can't keep up with the slides themselves. All right, so today we'll talk about an overview of Parkinson's disease, the increasing incidence of Parkinson's disease itself, the research efforts to date in Parkinson's disease. This includes disease-modifying and neuroprotective studies. What have we learned? The current and future avenues of research in Parkinson's disease. And this involves early identification of PD, targeting alpha-synuclein, which we'll talk about, gene-modifying therapy, and the lessons from Huntington's disease, which I will explain in depth. And also, most importantly, I think that everyone will want to pay attention to is what can we do now for people with Parkinson's disease.
Dr. Blewett, if I could just stop you briefly, the volume of your voice is sort of fading in and out. I don't know if you can get closer to the mic or...
Yeah, I apologize. Thank you very much for telling me. How is that?
That is better.
Good, good. I will project.
All righty.
LSVT loud, everybody, from your diaphragm. Okay. All right, so the cardinal motor symptoms of Parkinson's disease we will talk about first. So number one, there is slowness of movement. This is called bradykinesia. So in order to be diagnosed with Parkinson's, and this does address a couple of questions that I received, you have to have bradykinesia. This is the cardinal motor symptom of Parkinson's disease. In addition, there is a resting tremor and or limb rigidity. The new modified criteria, in order to have possible Parkinson's disease, you have bradykinesia plus one of those, so either resting tremor or limb rigidity. For probable Parkinson's disease, you have bradykinesia plus both of those. Postural instability, abnormal gait, those were considered previously to be initial symptoms of Parkinson's disease. However, we're finding now that they actually happen much later in the disease, not much later, but later. So the pathophysiology and etiology of Parkinson's disease, it's primarily due to a deficiency of dopamine. And there are several other neurotransmitters involved as well. But for the sake of this presentation, we'll focus on dopamine. So dopamine is a neurotransmitter responsible for communication between the substantia nigra, an area of the brain, and other brain regions. I like to make things very simple. Dopamine deficiency impairs smooth, purposeful movement. The easiest way to describe the role of dopamine, it's like the fuel in your brain that makes your body move. So if you consider dopamine gas for your car, your brain being the car, if you don't have dopamine, your car stalls and you can't move, you shake, etc. So what we try to do is replace the dopamine, and that's what most of the symptomatic therapies do in Parkinson's disease. So alpha-synuclein is a protein that's normally found in neurons, but there's an overproduction or misfolding of it. And then these clump together and they form this thing called a Lewy body. So Lewy bodies, you'll see here, this is the substantia nigra. This is a normal substantia nigra. You see the darkened pigmentation with the arrow. And the alpha-synuclein clumps together, forms this Lewy body, and then it unfortunately results in the lack of pigmentation and destruction of the substantia nigra. This is where the dopamine-producing cells occur. So you can understand how when this alpha-synuclein attacks the substantia nigra, that there is the lack of dopamine. So there's many different, it's a multifactorial etiology of Parkinson's disease. So genes play a role, usually in younger patients, and the most common is LRRK2, leucine-rich repeat kinase. There's environmental toxins we're finding are very important, mainly pesticides. The fact that dopamine, as it's degraded itself, forms free radicals, and this can damage the cells. There is also here, there's been a study called Steady PD, which looked at a calcium channel modifier. The thought here was to basically reduce the amount of free radical stress that was happening in these cells. Unfortunately, this study was not effective. So there's a protein accumulation, so decreased degradation of alpha-synuclein blocks the chaperone-mediated autophagy. It's a fancy way of saying that the trash can doesn't work and everything gets blocked up. When this happens, there's protein aggregation. Again, this forms the Lewy body. oxidative stress plays a role in most diseases of the brain. There was a study called the SURE-PD study, which looked at urate. And this was inosine. What inosine does is it basically reduces the amount of uric acid. Excuse me. And uric acid. And so uric acid is thought to be an inflammatory compound. So to reduce the level of, to elevate the uric acid, it's found to be protective potentially against Parkinson's disease. So what this does is urate would elevate the inosine would elevate the uric acid to a level that is not toxic to cause gout and things of that nature, but that it would actually lower the inflammation that could cause the damage to the substantia nigra cells. So this trial unfortunately was ineffective. I was a principal investigator at a site for this, and unfortunately it found that it was not working. But I want to highlight this as I think that there's many flaws in the study design, although the principal investigator is excellent, but it highlights the problems with research to date in Parkinson's disease in general. So MPTP affects mitochondria. They use this in rat models of Parkinson's disease. So we know for a fact this definitely plays a role. Inflammation accelerates, but does not alone cause neurodegeneration. So that's not going to be, I don't think, our silver bullet. Apoptosis cascade is basically what happens to all these cells in response to the excess damage. Ultimately, you end up with Parkinson's disease and the symptoms we discussed earlier. So the incidence of Parkinson's disease, this is the second most common neurodegenerative disorder in the world, but the incidence is increasing rapidly. Okay, so from 1990 to 2016, it has more than doubled. And I'm going to say that again, the incidence of Parkinson's disease in 25 years more than doubled. And it's expected to do so again. So how do we prevent the disease? Increasing physical activity. There's numerous questions about this. Please, I'm going to emphasize this throughout this presentation. Physical activity is very important in preventing Parkinson's disease. Reducing exposure to pesticides, improving access and care for effective treatments, and increasing research funding to understand the underlying causes and development of new therapies. And the good news, as a silver lining of the incidence of Parkinson's disease growing so rapidly, is that more money has to go into this to help cure it. We're going to have more problems in the world. As the number of people with Parkinson's disease increases, this is going to become basically a global crisis. And so the government is putting more money into funding for research studies for Parkinson's disease. So we're going to focus today on prevention and delay of disease progression. There's many other different kinds of studies, symptomatic monotherapy, adjunctive therapy, etc. But we will focus mainly on the prevention and delay of disease progression. So first of all, I would like to say that coenzyme Q10, nutritional supplements such as creatine, vitamin D remain popular, but there's no evidence of clinical benefit in Parkinson's disease. Quickly, I'd like to say that vitamin D is generally deficient as we age. And so there's a lot of studies showing there's a correlation between vitamin D deficiency and Parkinson's disease, but this is commonly found in the population anyway. Physical exercise, again, has also been investigated as a method of disease modification in Parkinson's disease. And preclinical studies suggest dopamine loss is reduced with exercise. Exercise promotes BDNF. The results of the studies to date are mixed, but the studies were low quality to date, so they need to be redone, I think. Therefore, the clinical practice implication is currently investigational, although I think that this is promising. So you can see here, so this is in movement disorders, our publication that we usually go to in Parkinson's disease. You can see the efficacy and conclusions of these different interventions. And you see for exercise, insufficient evidence. Why is this? You look at the quality score, 74, 62. Here's a good study that showed that basically there was no significant differences, and this was for coenzyme Q10. But again, I just want to highlight the role of kind of the problem with these studies. The study population was heterogeneous, so there's different kinds of Parkinson's disease. Not all kinds are the same. Everybody here who has Parkinson's disease knows that. So there's many different ways we can improve on the current research that we're doing. So there's been several epidemiological studies that have found an inverse correlation between tobacco smoking and risk of Parkinson's disease. One of the leaders in our field said, well, yes, of course, course, because people who smoke get cancer and they pass away before they can get Parkinson's disease. And the clinical trial was called NIC-PD. The conclusion was that transdermal nicotine does not slow the progression in early PD and may, in fact, worsen the symptoms of Parkinson's disease, which I think is good news, so we don't promote nicotine. All right, so levodopa in early Parkinson's disease trial. This is called the LEAP trial. There was a previous study done back in 1995, I believe, called the L-DOPA study. And this showed that patients who received levodopa earlier had a clinical benefit 2 weeks after that medication was withdrawn. So it was unclear if it was disease modification or prolonged symptomatic relief of the carbidopa-levodopa. The LEAP trial that was redone basically to analyze the efficacy of levodopa in early Parkinson's disease, it was done a little bit more systematically. And so basically carbidopa-levodopa was given for 80 weeks in an early start group. And then there was a placebo group for 40 weeks that also got carbidopa-levodopa after 40 weeks. So the initial group gets it for all 80 weeks. The placebo group only gets it for the last 40 weeks. The conclusions were there were no difference in the severity of symptoms between these two groups. However, there were no difference in the complications due to levodopa. So this doesn't argue towards starting levodopa earlier. It doesn't argue delaying it. And basically everybody I know who goes on the internet finds that levodopa after 5 years is going to cause horrible complications. I think if you manage it properly, that should not happen. That's just an aside.
Dr. Blewett?
Yes.
We're still getting your mic fading in and out a little bit.
I'm very sorry. I'm trying to
that you can make?
Yeah, let's see here. Turn it off. Can you hear me?
I can.
Okay. Just let me know. I'll do my best. That's very strange. I haven't had this problem before.
Yeah, that is. Is it plugged into the side of the computer real tightly?
No, I actually have just a built-in microphone on my computer, which is why
Gotcha.
Yeah.
All right. We'll try it again.
Yeah. All right, I'll do my best. So ultimately, no studies to date have identified a clinically useful intervention to prevent or delay disease progression in Parkinson's disease. That's our conclusion to date. So what are the problems that we've had with the study so far? We've had difficulty measuring disease progression. That's one huge problem. The clinical rating scales may be insufficient, although I don't think this is as big of an issue. Accounting for the Parkinson's disease subtypes is huge. There are very many different kinds of Parkinson's disease. We've identified essentially 3. There's tremor predominant, postural instability, gait disorder, and akinetic rigid, depending upon who you ask. Very different disease courses. And so there's also the fact that the interventions are evaluated in patients with early motor features of Parkinson's disease. What we'd like to do is to do this in the prodromal phase, and I'll talk about what that is in a little bit. So overall, the area of slowing and preventing disease progression in Parkinson's disease remains a large unmet need. So here are the current and future avenues of research in Parkinson's. Again, these prodromal features occur well before the onset of motor symptoms. One of the questions asked how long before, in general about 5 to 10 years, but we are uncertain. The most influential prodromal feature is REM behavioral disorder. This is talking in sleep or acting out dreams, constipation, anosmia, excessive daytime sleepiness, lightheadedness when standing, urinary problems, erectile dysfunction, depression, and anxiety without depression. The major ones are the top 3: REM behavioral disorder, constipation, and anosmia. So over 90% of patients will have impaired sense of smell at the beginning of the diagnosis. However, 50% of people over 65 have this as well. So more importantly, I think, is the REM behavioral disorder, also called RBD. 50 to 70% of these patients will develop a synucleinopathy. So the Movement Disorders Society criteria for prodromal symptoms is 99% specific in predicting the later development of PD. And what they're trying to do now is to identify people who have these prodromal features, intervene before they develop Parkinson's disease to determine if these interventions are successful. So in terms of the alpha-synuclein, going back to the bugger that causes the Parkinson's disease in the first place, the preclinical data has demonstrated the ability to block transmission of pathogenic forms of this and to slow the PD-related neurodegeneration. And I think most promising, which is another question that was raised, is these monoclonal antibodies and or vaccines against alpha-synuclein. So we'll discuss all these as a highlight. I'm going to speed through these because we go through everything in detail. Excuse me. Here's the first one. There is monoclonal antibody. This is a study called Pasadena. This is a phase 2 study to evaluate the efficacy of prasinezumab. Anytime you see an amab, it's usually a monoclonal antibody if it ends in amab. So this is the first potentially disease-modifying anti-alpha-synuclein antibody for efficacy in patients with Parkinson's. And as we said before, it's supposed to block the transmission. Various animal cellular models showed efficacy. The phase 2 study was done. It has been completed. So it says here active, it's almost completed, but they are not recruiting currently. We are awaiting the results from this trial. There's also a trial called SPARK. This is another monoclonal antibody. It's BIIB054. This is a disease-modifying monoclonal antibody against alpha-synuclein. Status, again, active, not recruiting. We're waiting for the results of this as well. There's many more. This is a very interesting one, I think. This is an APHARIS trial. It's a phase 1 clinical trial, which means it's basically testing for safety of a subcutaneous vaccine. Okay, this vaccine has prompted the body to promote alpha-synuclein antibodies, similar to the influenza vaccine. So in 19 of 22 people that they tested, they found this immune response. So 12 of those 19 developed alpha-synuclein antibodies in the bloodstream. So this suggests that the vaccine can produce antibodies against alpha-synuclein. The phase 2 trial will start shortly, sites and country to be announced. And there's many different other methods of studies that are being conducted currently in order to prevent the progression of alpha-synuclein, anti-aggregation, prevent the clumping, increase the clearance, and this is nilotinib, which we will discuss. That was a question as well. Decrease alpha-synuclein expression. And to discuss nilotinib, this is a chemotherapy agent that was FDA approved for the treatment of chronic myelogenous leukemia, CML. It blocks something called BCR-ABL that promotes the development of cancer, also linked to oxidative stress and alpha-synuclein-induced neurodegeneration. There was a small proof of concept trial performed at Georgetown. The results were a bit dramatic, and it was also not done as a placebo-controlled trial, so everybody just got the compound. Reportedly, there were people leaping out of their wheelchairs in later stages of Parkinson's disease, and this gained a lot of hype, but also a lot of scrutiny, and therefore it's being done more systematically now. The phase 2 study, again, safety and efficacy, or excuse me, safety met its primary objectives. The phase 3 trial will be conducted soon. Genetic therapies, I think, are probably the most promising. There's inhibition of LRRK2. I'm going to go into more detail into these later, so I'll skip through these slides. Upregulation of glucocerebrosidase. This is for GBA patients. GBA is glucocerebrosidase mutation that can cause Parkinson's disease, as well as another disease called Gaucher's and some other diseases as well. One of the, well, actually, I'll talk about that later. Okay. So antisense oligonucleotide therapy, I want to talk about this because this is promising in Huntington's disease. Again, bringing back to how I think that Huntington's disease can relate to potentially, it teaches us some lessons. So ASO therapy, very simply going back to Science 101, there's DNA. DNA makes RNA. RNA makes a protein. What this does is it blocks the RNA from making the protein. In Huntington's, this is very straightforward because Huntington's basically has a mutant Huntington protein that gets expressed. So this blocks it. So this, I'll skip through these for time's sake. Excuse me. And so the point being that I want to take a second. Until 2008, there were no FDA-approved medications for the treatment of chorea in Huntington's disease. Tetrabenazine was approved in 2008, but was used in Europe since 1971. So 46 years, there were 46 years between developments of a symptomatic therapy for Huntington's disease. So Parkinson's disease can often seem hopeless, futile, etc. there's worse. Huntington's disease, there was basically nothing for a long time. So they did a phase 1, phase 2 trial to evaluate the safety and tolerability. It was completed in 2017, very, very, very promising, okay? So then they extended this called the BN40423 as Generation HD, looking at early Huntington's disease, early manifest Huntington's disease patients. Very significantly, what this did was blocking this mutant Huntington protein with this ASO therapy lowered the levels in the cerebrospinal fluid up to 60%. And this is really dramatic and very exciting for the field in general. There was also exploratory analysis. The phase 1/2A study doesn't analyze that, but they found some exploratory analyses showing that there was some improvement in clinical measures as well. So now they're doing a phase 3 clinical trial, which, I have the great privilege and pleasure of being a principal investigator for. And it's gone into open label extension, meaning we're giving everybody this now. How we do it is we do a lumbar puncture, take out some fluid, replace it with this antisense oligonucleotide therapy. It's called an intrathecal infusion. I can't release any sensitive data, but I will say it's a very exciting project. So there's other targets as well. I'm going to race through these because this is more scientific. Calcium homeostasis, iron chelation, insulin resistance, oxidative stress, autophagic dysfunction, again, the trash can. Lysosomal dysfunction, similarly, kind of degrades the alpha-synuclein. Mitochondrial dysfunction is definitely implicated. Neuroinflammation, implicated, but probably not solely responsible. So what can we do while we're waiting? Okay, and that's obviously relevant for everybody here. So the Mediterranean diet, this is non-refined cereals, fruits, vegetables, legumes, leafy vegetables, things of that nature, potatoes, not meat, not chicken, not full-fat dairy products. They evaluated the effects of this on prodromal Parkinson's disease, and those symptoms that occur before actual Parkinson's disease, acting out dreams, constipation, and difficulty smelling. So adherence was associated with a lower probability score for this prodromal Parkinson's disease, so less depression, constipation, less daytime sleepiness, urinary problems. They concluded that this may slow the possibility of, reduce the possibility of getting prodromal Parkinson's disease. This can thus prevent Parkinson's disease itself. Exercise, please. This is from anecdotal evidence. Anecdotal evidence basically means that we have seen this ourselves in clinic. Patients who exercise, people who exercise do better with Parkinson's disease in general. The studies need to catch up with what we're seeing in reality. So there's been mixed results from the studies to date, but it likely does improve the symptoms. Recommended amounts, this was a question, 30 to 45 minutes a day, 4 to 5 days a week. Types of exercise, cardiovascular, designed to improve balance stability. So bicycling, walking, jogging, running, Tai Chi, yoga, swimming. And there was a gentleman who had Parkinson's disease, relatively advanced, moderate advanced, and he set the Guinness Book of World Records for a longest distance swam. So he said it was the proudest moment of his life. Optimize your condition, talk with us. Ensure you're on the right medications. Make sure you're ready for when something is going to come out. New symptomatic therapies have been developed. Efforts are ongoing. This talk does not cover the symptomatic therapies necessarily, but what I'd like to mention quickly is there's a subcutaneous version of carbidopa-levodopa. There's the Duopa, which is the pump. It's an external device. This is subcutaneous. It has actually already been released in Europe and is successful, and so we're evaluating it here as well. I think it's very exciting. Keep yourself in the best condition possible. Stay up to date on the current research too. Talk with your doctor about ongoing clinical trials. It is recommended to see a movement disorder specialist. I'm obviously biased, as I am one, but this is our specialty. We should be up to date on those. On these trials, the Michael J. Fox Clinical Trial Finder is very helpful as well. Review the websites of other organizations dedicated to helping those with Parkinson's disease. Do not be led astray. So the websites I really like are Michael J. Fox, Parkinson's Foundation, Davis-Finney, the three major ones. Discuss these studies again with your movement disorder specialist if you find them. So in conclusion, Parkinson's disease is a progressive neurodegenerative disorder. Studies to date have not yet found disease-modifying therapy. The incidence of Parkinson's is increasing rapidly. This means more funding. Several promising avenues of therapy are underway. This includes targeting alpha-synuclein by monoclonal antibodies or immunization, gene-modifying therapy, And then remember the lessons from Huntington's disease. There was essentially nothing for so long, and all of a sudden this came along. So there is hope. Continue to live a healthy lifestyle, eating right, exercise. Please exercise, cardiovascular if you can, and optimize your condition and stay up to date. And yes, of course, there is hope. I hope that this comes sooner rather than later. We are all waiting anxiously. And we received many questions in advance, so I will go through these. I will ask, before I go through these, so I can catch my breath too, is volume still fluctuating?
It is. Do you happen to have a headset that you could plug in before we go on to questions?
Yes, I will do that, and I apologize. I'm sorry.
No worries. We have one question to add at the beginning before you read the first of those that came in ahead of time. I want to make sure you're there to hear the question.
I am here. I apologize, Denise. Go ahead.
Terrific. No worries. Bart Narder asked, what does DO stand for? And are you a movement disorder specialist?
Yeah, good question. I get this a lot. Quickly, actually, I put the headset on. Has this improved anything?
So far, yes.
Okay, great. So DO is a doctor of osteopathic medicine, same as an MD, medical doctor. We have the same training, except that we learned something called osteopathic manipulative treatment. Osteopathic manipulative treatment is essentially chiropractic meets massage, effective, a little bit exaggerated the potential efficacy, but we also combine a more holistic approach, basically integrating different systems rather than looking solely at one system. But yes, completely legitimate. I took my DO and MD boards, went to MD residencies, MD fellowships, so yes.
Wonderful. And I didn't hear any cutting out in that
Very strange
explanation. So I guess we'll go on to our advanced questions.
All right, and I apologize about that again, everybody. So what do we know about exercise and halting the decline? We exercise again. Currently to date, we don't have efficacy shown via clinical trials. It's been mixed results, but the types of exercise that are superior are cardiovascular, things that catch balance, gait, things of that nature. So Tai Chi, yoga, bicycling, swimming, jogging, anything that's safe and as tolerated that gets your heart rate up. Weightlifting is not so important. Core strengthening is important. Given the pandemic, what is the status of research and funding for research in PD at the present time? Again, well, excuse me, to cover the pandemic itself, there was a delay. So clinical trials have been halted at most sites in the country and around the world. This has delayed things, but it has not stopped things. So for the time, it's pretty simple math. If we've been halted for 6 months, we're delayed by 6 months. And essentially that's where we're at right now. But things are starting to ramp up again, even here in the Bay Area. What research strategies are showing the most promise? Again, this would be, in my opinion, monoclonal antibodies or alpha-synuclein, monoclonal antibodies or vaccinations against alpha-synuclein. What country is considered at the cutting edge of PD research? So this is a hard question. I think Europe is not a country, but I will be vague on purpose because they're basically, the FDA is very good and it's strong and it makes sure that we have everything safe, but it also prohibits and delays things as well to ensure safety. So Europe is a bit more cutting edge than us. Potentially, this could potentially lead to more studies of compounds that could be dangerous, although I don't think this is the case. But I think Europe is more cutting edge. How does research on familial PD? We discussed this. So it's really important to understand these genetic forms of Parkinson's disease. If you have these genes, there's downstream effects of these genes, and they ultimately end up in all the symptoms of Parkinson's disease. So we need to know upstream what is causing these downstream effects that we can see. So it's very important for us to know from genes and genetic research in Parkinson's disease how we can stop these downstream effects by stopping the upstream causes. Genetic research in Parkinson's disease, we touched on this, LRRK2, GBA mutations, those are being done. There is a trial which touches on a different topic, which the question was, are there clinical trials in the Bay Area going on for Parkinson's disease, which I will get to as well. To answer that question in advance, University of California, San Francisco, Dr. Chad Christine has a very interesting study going on right now. It looks at a vector that is injected into putamen, and it actually can slow the breakdown of dopamine itself. And so this is very interesting. We were a site for the Pasadena study, again, which is active, Stanford, excuse me, which is active but not recruiting. There are some other studies coming up. I can't go into those in detail yet, but there are studies. And so if you're in the Bay Area, you're in a good place. Stanford, UCSF, and Parkinson's Institute all have good studies that are coming your way. So again, what triggers the death of neurons? It was everything we talked about. There's oxidative stress, mitochondrial dysfunction, the clumping of the alpha-synuclein. What is the best path to take to lessen stop progression? What can we do now is the way I like to see this. And again, that's going back to exercise and proper diet. These are the things we don't want to do, but we should do. And they do, I think, slow the progression of Parkinson's disease. Mediterranean diet is a little bit less evidence than exercise, a lot less evidence, but we'll be working more on exercise and evidence for Parkinson's disease. When can we expect a cure for Parkinson's disease? I've started 5 years ago in movement disorders and practicing out of fellowship. And so initially I said 5 to 10 years, and I have many patients who are holding me to this. I have one who I've seen for 3 years who now says you have 2 to 7. So we're working hard. I think honestly it might be longer than I initially thought. Getting more into research, just the pipeline, it takes a long time. Even if we found a cure, before it would get released, it would have to go through, be vetted, and that's a good thing. But it would just take a long time. So I think we're looking at about a decade before we can hopefully say something is here, and ready. But there are things now that are coming, and I do think in the next few years we should be able to identify and vet these in phase 1, phase 2 trials to get them ready for phase 3. This question was a bit specific. Autopsy studies show for medication resistance PD. STN DBS has controlled my symptoms well, but levodopa has not. Technically, you shouldn't get DBS unless the levodopa has worked for you, but there are many cases where DBS is effective if the levodopa has not. But in all honesty, there aren't necessarily autopsy studies for medication-resistant Parkinson's disease specifically. In regards to GBA-specific solutions, we discussed those. And so that's the glucose cerebrosidase mutation that can cause Parkinson's disease as well. Is Parkinson's disease becoming more prevalent in the population? Yes, we discussed this also, very much so, doubled, and it's about to double again. Is there a proof of concept for slowing or eliminating Parkinson's disease? There have been thousands of proof of concepts. Unfortunately, we need to translate those into reality. And so the problem is we have mouse models, we have cellular models, and then we have humans. And oftentimes there's a very big disconnect, I'd say almost always. And so there's many proof of concepts. The problem is the translational aspect of getting that into humans and having it work. What institutions or organizations are leading the way in the cure or treatment of Parkinson's disease? Michael J. Fox is a very good foundation. Again, Parkinson's Foundation. Davis Finney is excellent as well. Is there any research going on now in the Bay Area? Yes, tons, both at the institutions at the 3 institutions I mentioned and outside. This is a good place to be for research in Parkinson's disease. What do we know from research about whether PD causes dementia? So there's this, and I'm sorry, your wife has Parkinson's disease, and how can I know if her dementia is caused by Parkinson's disease? And so Parkinson's disease can cause dementia. Again, it's this alpha-synuclein, it's where it propagates. So alpha-synuclein can propagate in the brainstem and in the substantia nigra basal ganglia. These are the subcortical or inside regions of the brain. If it affects the cortical regions, then you can have dementia being caused by this. If there is Parkinson's disease and dementia, it's likely secondary to Parkinson's disease, but there is also mixed Alzheimer's pathology now we're finding with Parkinson's disease. So it's, I would say, actually impossible to know specifically if dementia is caused by Parkinson's disease, but but I hope that at least gives some information regarding that question. What is the status of research on stem cell replacement? I actually did a little bit of investigation before I came on for this question. I was very excited about stem cell replacement initially. Then they were finding that the stem cells would be injected, but they would actually adopt the features of the Parkinson's disease cells, meaning that they would not produce dopamine. And so what they're doing now is, instead of using human fetal tissue, they're using human pluripotent stem cells, HPSCs. This is being done. I just read Nature, which is basically our top publication for science research. And I just read a review on this, and it's a bit of ways. And so their efforts are ongoing, but it is a bit before it's going to actually be. In regards to this question I saw for imufloxacin, I did look this up. I only saw a very little amount of information, but what I did read, and this is with limited information and insight, was that it suppresses the immune system. Therefore, that's dangerous. This is like taking a chemotherapy agent. And so this should be vetted like nilotinib did with phase 1 and phase 2 trials to make sure it's safe before you actually go to this. I caution my patients, there are a lot of people who will take advantage of these diseases. I think it's sick, horrible. So be very careful. Do something that's vetted. Don't go to some small institution. Always be careful about throwing your money into something. Most clinical trials, you should be able to participate without paying any money. Those are ethical. The diagnosis, the DAT scan, what the DAT scan does is it differentiates Parkinsonism. This is what the FDA approved indication is to differentiate Parkinsonism from essential tremor. What it does is shows dopamine deficiency. This indicates the form of Parkinsonism, not necessarily Parkinson's disease. It could be one of the other 4 major kinds of atypical Parkinsonism, but it is 93% accurate in the diagnosis of Parkinson's disease. That's the latest literature, whereas a movement disorder specialist is essentially 83 or 84% accurate in our diagnosis. So it can be a bit more specific when we're not sure. In relation to this question how does PD compare with essential tremor? Essential tremor is a tremor that occurs when the hands are held up or when moving. So people who are attempting to eat with peas on a fork and the peas will fall off because it's shaking, that's not Parkinson's. It could be a bit of Parkinson's, but essentially that's called a kinetic tremor. And that's more frequently seen with an essential tremor than with Parkinson's disease. So again, the DAT scan can help you differentiate these two. The treatment options are different, so it is important to differentiate this. Can someone be given a diagnosis of Parkinson's disease with tremor and a bunch of non-motor symptoms? What if it's an action tremor? Going back to the diagnostic criteria, you have to have slowness of movement, and then in addition, stiffness or a rest tremor. You have to have the slowness of movement. So if you just have a tremor and non-motor symptoms, then technically no, you cannot call that Parkinson's disease. If it's an action tremor, it makes it even more unlikely. There are a lot of cases of overlap between essential tremor and Parkinson's disease. Many times I've seen people come in with 20, 30 years of essential tremor who develop mild Parkinson's disease. This is usually less severe. The prognosis is better. So this is something to consider as well. Ocular instability is not used to make a diagnosis of PD. It's more found in cerebellar disorders and also in something called PSP, progressive supranuclear palsy, which is a form of Parkinsonism, but to answer your question, no. If Sinemet has no effect on tremors, is it beneficial to stop taking or reduce Sinemet to reduce the risk of L-DOPA-induced dyskinesia? I would say yes. If your symptom is a tremor, mainly, predominantly, then why take a medication if it's not benefiting you and only causing potential side effects? However, a lot of times, this relates to the next question. How can we tell if Sinemet is working? We see not much noticeable difference after 3 years. When should we go up or down in dose? The point is that when you start these medications, if you do it properly, you titrate up very slowly. So you only do about a half a pill a day for a week. Then you go half a pill twice a day for a week, and then a half a pill 3 times a day until you get up to 1 or 2 pills 3 times a day, depending on who you ask. The purpose of this, that I'm giving this anecdote for, is that it's like watching a blade of grass grow. You can't see it, the blade of grass grow, watching it just with your eyes. You have to fast frame. And so why I'm saying this is that if you ramp up very slowly with Sinemet, then it is going to not be as noticeable, the improvement. If you start it right away, you can get nausea, lightheadedness, sleepiness, etc. So you want to go slowly. When you go slowly, you don't see the immediate improvement that you might if you just take it immediately. The point being that, going back to the effect on tremors, that Sinemet may be having more of an effect than you think it is. And so you can taper down off of it slowly, see if there was an improvement, and then go back on it. There's no harm done there as long as there's no problems with gait or balance. The best alternatives to Sinemet, if it isn't well tolerated, there are several. And so there's dopamine agonists, and these are forms of, they stimulate dopamine receptors, but they do not bind to them. Therefore, they're usually used in early Parkinson's disease. And this is an alternative for you as well. It depends on the symptoms themselves. Amantadine can be used. It's another medication that can be used for freezing of gait and also for tremor. Artane or trihexyphenidyl can also be used for tremor, resting tremor. There are several different alternatives, but you should discuss this with your doctor specifically. And I would recommend, again, a movement disorder specialist. So what is the treatment for dementia? Does it matter if the dementia is caused by PD or something else? The first answer to the first question is yes, there are treatments for dementia, symptomatic therapies, and these basically look at the cholinergic symptom. Like dopamine causes the problems of Parkinson's, there's also a cholinergic system that is involved in our cognition. And so it does matter if the dementia is caused by Parkinson's or something else. There's basically 3 different cholinesterase inhibitors that work. And so 2 of them are indicated for Alzheimer's, although they can have an effect in Parkinson's. Those are called donepezil or Aricept and memantine. And then there's one for Parkinson's itself called rivastigmine. This is a pill or a patch. Rivastigmine is thought to improve executive function in Parkinson's disease, may improve balance depending upon the study. So rivastigmine is typically the one used for dementia with Parkinson's disease. There's another medication called pimavanserin or Nuplazid, which is used for the Parkinson's disease psychosis, which I'm looping in here because it is a form of cognitive dysfunction in Parkinson's disease. It can help with hallucinations and delusions. What is the future of DBS? That is answered in the next question, which is what is closed loop DBS? Is closed loop DBS better quality or just longer battery life? Deep brain stimulation is DBS. This is the surgery that everybody knows about for Parkinson's disease. And so the future of DBS, right now, they're looking at this closed loop. So previously there was open loop. You program the deep brain stimulation, and then you leave at the office and you stay on those settings. That was called open loop DBS. Closed loop DBS is now being investigated. Our director, Dr. Helen Bronte-Stewart, is one of the innovators of this, and it is quite brilliant. And basically what it does is it looks at the deep brain stimulation tends to adapt then to the neural signals that can cause Parkinson's. So specifically, there are these things called beta band fluctuations or oscillations and bursts. And when those occur, that the closed loop deep brain stimulation can actually adapt and sense these and modify the settings in order to control the symptoms of Parkinson's disease. It's being looked at for freezing of gait, which is a very difficult symptom to treat in Parkinson's disease, also for the general symptoms of Parkinson's as well. So is delaying the progression of Parkinson's a cure? I thought this was a great question, very insightful, philosophical. No. It's not a cure. A cure to me would indicate that we have solved this, that, a cure is cancer in remission, that doesn't come back, that stops it. What I think our field should do first is find something that slows the progression. Let's not go for the touchdown or the home run, get a single, get a bunt. Okay, make some progress in disease modifying therapies. And so I think that's where our field really needs to do first.